Okay, so remember when we talk about inhalants, there's properties that determine how agents work, how we use them. So when you talk about the properties of inhalants, vapor pressure, partition coefficient, MAC, and solubility are all pertaining. And vapor pressure, it's the tendency that it turns into a gas. The agents that you guys use currently, SIBO and ISO, are associated with a high vapor pressure, which means they're considered volatile anesthetics. And if, volatile, you don't have control. Hence, you need a precision vaporizer to deliver it in a controlled way. And vapor pressure, high vapor pressure agents, well, all inhalant anesthetics, temperature can affect the rate of vaporization. If you think about, if you poured it in a room and it was cold or hot, obviously the warmer the room, it's going to increase the rate of vaporization. Hence, that's why the vaporizers do have a temperature control mechanism to try to control that temperature, to control the rate of vaporization. So the volatile agents are ISO, SIBO, and halothane. And again, you don't use halothane clinically, but it probably will be brought up on the boards. And they are specific to their vaporizer. And then methoxyfluorine was the low vapor pressure, can use a non-precision vaporizer. The blood gas partition coefficient, I prefer to talk about the blood gas solubility of the agent. And this tells us how fast they will be induced with that agent. And so the agents that have a low blood gas solubility are associated with a quicker induction and a quicker recovery because they are less soluble in the blood. And if I think about solubility, dissolvability, the agent has to go from the alveoli to the blood. When it hits the blood, is it going to solubilize into the tissues and the other compartments? If it has a low solubility, it has a tendency to remain within the blood and to remain intact and not get absorbed into the tissues. Hence, when that blood goes to the brain, by the time the blood flow goes from the lungs to the brain, it's maintained a higher concentration within the blood. It produces quick induction, quick recovery, and quick changes during anesthesia. You can change them from 2% to 1%, and within about 3 to 5 minutes, you can see an effect of turning them down. Where you have high blood gas solubility, then that tends to dissolve into the tissues or solubilize into the tissues, into the plastics even, with the breathing system in the bag. And then that's associated with a slow induction, slower recovery, and it tends to, slower changes. When you go from 1% to, or 2% to 1%, the changes aren't going to be as rapid. Now, it kind of determines how we use the agent. And this is what I did on the test. I said, if I have a cat that's aggressive and I have to mask it or box it down, and I had halothane and sevoflurane, sevoflurane has the lowest blood gas solubility, meaning it's the quickest induction and quickest recovery. Well, if I'm doing something stressful like a mask, I want to do something that's going to be quick and gives you more control. And so your low solubility agents had that effect. And that's and also recovery. Now, I have made this clinical note in lecture in anesthesia, but I'll remind you, speed on recovery isn't always a benefit. I've heard that in equine medicine, sevoflurane was not well received. I mean, this is very doctor dependent. One doctor might like one doctor might like the other, but I know in a horse, we don't necessarily want them waking up very quickly. Now, maybe if it's a critical foal or a very, very sick colic, but for an average horse, we kind of like the drugs to kind of hang over in recovery, so they wake up slower. And so SIBO was a little quick, and I talked to Niemer in exotics, and I had assumed, oh, you got to love SIBO for exotics. Dr. Lennox did not like SIBO. They thought it was too quick. So sometimes, if you have a patient that's going to wake up, if you have a bird or say a rabbit and maybe they're hyper excitable, sometimes having a little bit of hangover of your agents in recovery is a benefit because they'll wake up slower. So again, it's variable. If I have a critical patient, I like SIBO a little better than ISO because, you have that rapid change. And if I have to make rapid changes because my patient is unstable, I have more flexibility. ISO is still very quick. SIBO is just a little bit faster. Both of them, though, you have to remember, produce dose-dependent respiratory depression, vasodilation, cardiodepression, CNS depression. The higher the percent, the worse you're going to see those effects. So again, in a more critical patient, you want a drug that you can make rapid changes. So again, you want to try to keep those percents as low as possible. We don't run max, like I said, I've told you yesterday, if you've got a surgery patient above 3%, you're going up to 4%, you need more analgesia on board. That patient is reacting to something. You have not met their analgesic needs. I've had animals during fracture repairs. Now we've done epidurals and we've done morphine and we've done very potent analgesics. I had this dog on a 6-hour surgery for a 0.5% isoflurane. You can meet analgesia. It can be done. So these are just things to think about. Now MAC, again, this is a definition I have you guys memorize: minimum alveolar concentration. It is the percent or amount of agent where 50% of animals will not react to a painful stimulus. Every inhalant has a MAC value. Isoflurane's 1.2, halothane was 0.76, SIBO 2.1. You guys have these notes from anesthesia. But remember what that means is that so ISO 1.2 is MAC. If you took 10 dogs and gave them now nothing else on board, when they developed MAC values for these agents, this was the only agent being used. So no pre-meds, no inductions, but basically at 1.2% in an awake dog, 50% of them will react to a painful stimulus, meaning 5 of them, and 5 of them will not react. Now that painful stimulus is like a toe pinch. Okay, it's not like abdominal surgery or extractions or something like that. So, but what MAC tells me is potency. Okay, let me go back. Solubility tells me how quick my agent is. Now, I told you that the lowest solubility agent we have is sevoflurane, but sevoflurane of the agents has the highest MAC value. That just tells me that sevoflurane is not as potent as isoflurane or halothane. Okay, so I've gone from halothane 0.76, ISO 1.2, SIBO 2.1. So the MAC has increased in those agents. It's just not as potent. That's the reason the sevoflurane vaporizer goes to 8%, because you need a vaporizer that can deliver more of it because of its lower MAC. It's just not as potent, but it's your quickest induction. I told you in lecture, potency does not equal speed of induction. And isoflurane is the polar opposite. It is the least potent because of the MAC, but it's the fastest induction because it has the lowest solubility. So just understanding what these concepts mean. And, a lot of board exams questions is like, what does MAC mean to my patient? It's kind of a starting point. How much gas do I deliver to my patient? Now, what lowers MAC? How do I lower that value? Well, first of all, when you give an animal pre-meds and inductions, theoretically, remember, MAC was established without anything else on board. So let's go back to, let me take those dogs, we're going to pinch their toe. Now, let me take those dogs and give them some butorphanol and some dexdomitor and maybe propofol. I'm probably not going to need as much ISO to pinch their toe because they have analgesia, they have sedation on board. So pre-meds, the justification to pre-med every patient to surgery is MAC sparing, is to lower your MAC value. Remember, inhalants are not innocuous, completely safe agents. Okay, they can kill a patient, I promise you. So, people tend to think, just run whatever percent of gas. Well, you're always trying to lower the amount of gas you can run to a patient. That's always your goal. So if you can give analgesia, give sedation, give induction agent, that's going to lower your inhalant, and that's going to be MAC sparing. But also, if they're older patients, pediatric patients, hepatic disease, maybe cardiovascular disease, pregnant, those are all things that lower. You shouldn't need as much MAC. It's meaning you shouldn't need as high of a percent in those patients. But again, every patient is individual. This is why it's very difficult, when I teach you guys anesthesia and you go into surgery, and everyone's like, well, what do I start my ISO at? And I'm like, it's variable. How old is your patient? How hard did their pre-meds hit them? What are you doing to your patient? So that's why I've kind of told you guys, on average, I maybe start 1.5%, 2% on ISO, and then you evaluate your vitals and go from there. So MAC is just, and if, you find my notes from anesthesia, about 1 times MAC is light anesthesia, 1.5 times MAC is surgical anesthesia, 2 times MAC is deep anesthesia. So if 1.2 is my MAC of ISO, 1 times, 1.2 is 1.2. So 1.2 would be light. 1.5 times that is 1.8. So that's giving you an idea of you probably need at least 1.8 for surgery. And then if you're double that, which is 2.4, that's probably a little too deep. And that's where, that's why I said I don't really like ISO in my patient really above 2.5%. You really need to be doing something to lower that amount. Isoflurane is the most common. Dogs and horses, we do use it in cats, we use it in rabbits, so there's always off-label use. It does have a high vapor pressure, low blood gas coefficient or solubility, so quick induction, quick recovery. Again, it says 1.3 to 1.63. Now the 1.63 is in the cat. Why is the MAC higher in a cat if they're smaller than a dog? Why are the MACs always higher in a cat?
Is their metabolism different?
Yep, higher metabolism. So again, whenever you look up your MAC values, they're always going to be higher in a cat than they are a dog because of metabolism. So, that does affect it. It has a low rubber solubility. That became, when we used the old agents, and I'm old, so I can say this, I didn't use methoxyfluorine, I'm not that old, but halothane it was highly rubber soluble, meaning that the tubing and the bag, which are rubber, do absorb some of that agent. You could definitely smell kind of like leftover agent in the tubing. So you probably think, why is that? Well, if your plastic or your rubber is absorbing some of your agent, not as much as getting to your patient. That's kind of where that clinical application. No preservatives. It's stable at room temperature. It does maintain cardiovascular function. The only thing I will say is that it is a very potent vasodilator. Now, what have I told you guys time and time and time again? If you have a drug and it vasodilates the vessels, what does the heart rate do in response to vasodilation? Does it speed up or slow down typically? The blood vessels are attached to the heart. And if they get bigger, what does the heart rate want to do? What does the heart want to do?
Slow down.
Flip that. You do want to speed up. Well,
Oh, it speeds up. Okay.
It wants to fill the pipes. Okay. Remember, it's kind of like a pump in a tubing system. So if you have a drug and you keep turning up ISO and they keep getting vasodilated, sometimes what will happen is the heart rate's going to speed up because it's trying to keep the vessels full, if you think of it that way. And remember, I've told you guys, and this is a practical tip, if I told you that if you have a hypotensive patient and sometimes you can get tachycardia or an increase in heart rate, and most people interpret an increase in heart rate in anesthesia as they're getting light or feeling something, which a lot of the time is true. But sometimes in the face of vasodilation, which can drop blood pressure, the heart rate will try to increase. Now, Nicole, what I think you're thinking about is the opposite. When you have vasoconstriction from like dextrometor, when you have vasoconstriction, that increases blood pressure and the heart's reaction is to slow down. So with dextrometor, it's the opposite. You get a massive vasoconstriction from the drug. And what that does is it sends all the blood from the periphery to the core, heart, brain, lungs. When all that blood gets kind of shoved back to the heart, so to speak, and you have these narrowed vessels, that increases. I mean, if you took blood pressures on these dogs after dextrometor pre-med, you'd sometimes get systolics up in the 200s. Yeah. And, so when the heart slows down after dextrometor, that's a physiologic response to the spike in blood pressure and vasoconstriction. That's what's supposed to happen. Now, again, so we have competing, but when I think about cardiovascular function, isoflurane, its effect on the myocardium, the rhythm, is not as great. But because it's a vasodilator, when you run higher percentages of isoflurane, it can increase work on the heart. We use this in cardiac patients all the time, but I'm always conscious of the fact that if I have a low blood pressure, it's reflective on what my heart needs to do to counteract that blood pressure. Now, it does maintain good flow, and it is almost completely eliminated through the lungs. So now, you don't have significant liver or kidney metabolism needed to get rid of this drug. So it's nice if you have hepatic or renal metabolism issues, elevated liver enzymes, kidney enzymes, things like that. There is no analgesia with these agents. So again, you still need to give them something for pain. And sevoflurane, as in comparison, has a very high pressure like ISO, so it needs a precision vaporizer. It has the lowest blood gas partition coefficient, or the lowest blood gas solubility. So it's the quickest induction and quickest recovery because it doesn't distribute to the tissues, doesn't dissolve in the low rubber solubility, so it doesn't dissolve in the plastic. Pretty much you reach concentrations in the brain very rapidly. Hence, when you turn off the agent, it leaves the brain and they recover rapidly. It would be great for mask or chamber induction. That's what I would choose because, again, it sucks to mask patients and boxing them down. I hate it. So I want to use the fastest drug I have to get that accomplished as quick as possible. And this would be my drug of choice. Now, 2.3 to 2.58, again, it has a higher MAC value. So again, it's not as potent as iso or halothane was. But again, that doesn't equal speed. Now, adverse effects. Minimal cardiovascular depression like iso. But like iso, it's a potent vasodilator. So when you start running higher percents of SIBO, vasodilation is going to be worse. Hence, monitoring blood pressure is going to be key. Now, what do I do if I have low blood pressure with an inhalant? The number one thing you do is try to turn down your inhalant. And a lot of times that fixes the problem. Unfortunately, and hopefully you guys in surgery, well, let me say what I'm going to say, unfortunately. Sometimes when you get into practice, you might be working with on the job trained people or people that have done this a long time. And some people put them at a percent and they're like, oh, you just leave them at 3%. They'll be fine. Well, I've told you, yes, they can survive deep anesthesia. An animal can wake up. Physiologically, things are happening, and we know that we should probably try to run a lower percent. So you're always going to try to turn them down, find the lowest percent that you can run. The respiratory depression is dose dependent. Again, when you're at the higher percentages, you're going to see, and when I say respiratory depression, remember that's rate and depth. So they're not going to breathe as often. They're also not going to breathe as deep. So again, if I see my respiratory rate declining, as I'm doing my readings and I'm like, it's just going down, 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 I'm going to turn down my inhalant. Now, a tip, sometimes I'm battling blood pressure, and that's probably the number one thing I battle during anesthesia on a lot of patients is trying to keep their blood pressure above that mean of 60 to maintain kidney perfusion, to maintain tissue perfusion. Sometimes I try to turn them down and then they kind of huff and puff or their heart rate goes up. Well, in a patient like that, if I'm battling blood pressure, I'll usually talk to my doctor and we'll usually give an injection of analgesia, kind of top them off. It may not be the same amount we pre-medded with. It might be half of that, but usually I'm communicating with my doctor and I'm saying, hey, can I give him something because I'm trying to turn him down, but every time I turn him down to fix the blood pressure, he starts waking up. And I don't want that either. The other thing you can consider is a fluid bolus and give a little boost of, fluids. I usually try to turn them down first because that's the quickest, easiest thing to do. And a lot of times that fixes the problem. The thing that I worry about on sevoflurane, that's just a caution, is they can wake up quickly. And hopefully you guys, I don't know if you've gotten to compare when you've done the surgery patient versus the dental patient, the difference in the drug. I mean, again, ISO and SIBO are so similar. Kind of what happened, and I don't know, maybe my doctors are in the room listening to me right now. I've had doctors have one bad experience with a drug and then they're like, I don't want to use it anymore. I don't like this. When SIBO came out and it was sent to clinics and people kind of got to try it out, and sometimes, they'll have one bad experience and, okay, I don't like this drug. It could have been multiple experiences. I'm not saying that didn't happen, but I've worked with a few doctors. There's like, oh my God, I used that one time. I hated it. And it's like, well, maybe it was just that patient. Maybe it wasn't that drug at all, but it is very quick. So there's some practice needed with sevoflurane so that you do run it at a adequate level. So like what you guys have probably found in surgery, usually when they're closing the skin, sometimes I will turn them off. Like the doctor has maybe 2 skin sutures left. And, I usually like to give them 5 minutes of oxygen after I turn off my inhalant. But sometimes I've seen patients react worse to the skin suturing than the sub-Q stitches or the surgery. So not every patient can always be turned off during skin suturing. It kind of depends on the patient. Were they deep before? But with sevoflurane, sometimes I'll leave them on till the end of the procedure because they can wait. You want to make sure you're ready when they wake up. In an ideal world, you turn off the anesthetic, you do 5 minutes of oxygen, you turn off the oxygen, you deflate your cuff, and they wake up nice and smooth. But like I said, I will say they can wake up pretty rapid from this. So when we walk them down, which is like, okay, we're done with surgery, she's starting the skin or he's starting the sub-Q layer, I generally try to start to walk them down so that by the time they're done, we are kind of waking up. I mean, that's ideal, but you've probably found that doesn't happen with every patient. Sometimes you turn them off and you're ripping that tube out because they're like awake. So this is very quick. That's the main thing I wanted to say about this drug. Are there any questions as far as the properties of inhalants? Oh, it wasn't in this PowerPoint. And the only reason, so in my anesthesia notes, when I do lecture you about halothane, halothane, again, is not clinically used anymore, but the board exam, they talk about these new agents in comparison to the old agents. So halothane did have a higher blood gas solubility. So again, it was associated with a longer induction and a longer recovery because of that different vapor pressure. It had the lowest of halothane isocevo, it had the lowest MAC around 0.76. So it just meant that it was more potent. It did go to 5. The halothane vaporizer was just like a iso vaporizer. The max you could give is 5%. Now, it still was considered a high vapor pressure anesthetic volatile. So it was recommended to use a precision vaporizer, although some clinics did use the non-precision, the jar and wick vaporizer with it. The oldest agent that I've talked to you guys about is methoxyflurane, and that had the highest blood gas solubility, so the slowest induction, slowest recovery. It had a low vapor pressure, so it could be used. It was suitable for that jar and a wick non-precision vaporizer. But if you get a question about vaporizers, remember 2 kinds, precision versus non-precision. Precision is vaporizer out of circuit, and non-precision is a vaporizer in the breathing circuit. So those are the key differences. And which do you have control over? Well, you have control over the out of circuit vaporizer because you're setting the amount being delivered to the circuit. When you have a vaporizer in the circuit, the patient breathes through the vaporizer. So any change in respiratory drive, respiratory rate, when I say drive, I mean effort. If they're breathing very, very deep, very rapid, they're pulling more air through that vaporizer. They're going to increase their concentration. Versus when you're out of circuit, they can breathe whatever respiratory rate they want. You're setting a consistent oxygen flow and percentage. And the respiratory rate, they're not pulling oxygen through the vaporizer. So their respiratory rate has no effect on your vaporizer. And that's how to understand for the boards the difference between the two. There is on your page, and let me see if I can pull up the Moodle page. Something that I want you to look at, and we can discuss tomorrow. I know I'm kind of cramming, I hate when I have to cram in stuff at the end, but here we are, this is week 8. Oh, where did you go? Oh, there you are. Okay. Sorry, my computer, I think, is ready to just revolt. Under your Moodle page, there was this sedative review diagram. And now this is something that Gillis had. Obviously, you have my anesthesia notes for drugs, but it talks about, agonist, partial agonist, agonist, antagonist. Talks about the effects of the opioids. She always liked to do these graphs. And there was also this section on the benzodiazepines, alpha-2 agonists. Remember when I talked about pre-meds or I talked about drugs, I said drugs have, so first of all, drugs have like families. Well, you have a broader, we have your sedative category, sedative/tranquilizer. And under that, you have phenothiazines, benzodiazepines, alpha-2 agonists. And then under benzodiazepines, what are the agents? Midazolam and diazepam. What are the alpha-2s? Xylazine, dexmedetomidine. Phenothiazines, I only talked about acepromazine. But remember, when you study your drugs, for example, the benzodiazepines, which are Valium and midazolam, obviously the drug family has effects, kind of like I talked about with inhalants. Here's the effects of inhalants in general. Okay, I can say here's the effects of benzodiazepines. But why would a company make a second drug that does the exact same thing as the first drug? So when diazepam is your gold standard, been around forever, benzodiazepine. So when they came out with midazolam, yes, does it do very similar things to diazepam? Yes. But what were the key differences? It's water soluble. I can give it in the muscle. Yeah, it is more expensive. But the advantage is, diazepam is not water soluble. And, if you give it in the muscle, it's not readily absorbed. So it's better designed to use it intravenously. So whenever you're comparing two drugs, and this applies to all drugs that you talk about, when you have a family of drugs, they have things in common, but they definitely have things that are different. It's like when I talk about my family, I have 2 kids. What do they have in common? They're my kids. They lived in my house. One's a boy, one's a girl. One does this, one does that. One's older, one's younger. You know what I'm saying? There's similarities and there's differences. And the key to studying any drugs, especially I focus on anesthesia, is what makes them different from each other. What are the different sometimes it's route, sometimes it is effects, sometimes it's duration of effects. So that's kind of, when you pick apart drugs, always kind of have that in the back of your mind. How am I going to differentiate? And like I've told you guys, when it comes to anesthesia, and I've always tried to put this on my tests, if I'm staring at 2 drugs for induction, what am I going to pick? I mean, and sometimes it's procedure, patient factors, side effects of one that I don't like, So keep that in the back of your mind. Go through and look at this chart, and we'll kind of review some drugs tomorrow, and then I'll talk about.
I have a question, Miss Lando.
Yes.
Did you get a haircut?
A while.
Sorry, unrelated.
A while back. It's just I did a straightening thing instead of a curling thing.
Very nice.
Well, thank you very much. Thank you. My goal is to kind of give you I have to run into dissection. When I come home, I want to send you guys an email as a guideline. Obviously, the sections on the final will just be the sections that we've covered, that we've already covered. And so I'll kind of talk about that timing and how we're going to do it. I'd like to meet with you one more time tomorrow to review and then give you kind of a window. But I'll give you some more guidance. So any other questions I can answer?
Yeah, what'd you do to your hand?
Oh, okay. So this was Sunday. Unfortunately, the same day I euthanized my cat. That morning, I slipped down the deck steps and kind of boom, 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 and tried to catch myself, I think. And this got stuck behind me. So I hyperextended my wrist and my shoulder. Yes, my Sunday was amazing. So I've been wrapping my wrist. It feels better when I wrap it.
Well, be careful.
Thank you. Yeah, because my name is Grace. No, I'm just kidding. There's a reason I'm not named Grace. So I told my daughter, I said, there's a reason you're not named Grace. Unfortunately. Okay, well, I have to run like the wind to try to get in the building here. So you'll probably see me. More information will be coming when I can get home and type. And so hang in there, review this stuff. I'll be in touch. Bye.
Thank you.
Bye. Oh, that's what's the problem. Okay.